going to make a few announcements and then and I will be introducing David. Okay, so everyone, first welcome. This will be our last session for the academic year. We typically take July and August off to some travel, some work, some play, and also to get our new calendar ready for the next academic year, beginning in September. We will stay with the first Wednesday of each month, 12 to 1, so that will not change. Let's see, recordings will be on YouTube, and one of us will post the link to that in the chat shortly. Cassie, if you know what it is, go ahead and do it. And we ask that you wait a couple days for that. And once again, that they're not, I'm not having them posted myself, so please don't try to contact me to get that done, because I won't be able to do that except to just send you to YouTube. Okay, let's see. As far as if you have not been on one of our seminars, the format that we use is about a 30 or 40-minute presentation from our speaker. And during that time, as questions come up, we ask you to put them in the chat, please, and we will address them in the order in which they've been in the chat. So if you get your questions in early, you'll get a response to it. It's just we have found that we have such a large audience that it becomes a little bit confusing, and some folks have let me know that they feel like they lose the track of the talk. So we've gone to chat. At the end of the talk, if you don't type or don't use chat, you can use the raise hand feature at the bottom of your screen. And if you raise your hand, then that will put you in the front of the screen, and our speaker will address your question that way too. Okay, Cassie, any other announcements?
No, nothing from me.
All right. It is 2 minutes past 12. So I am really delighted to introduce you to today's speaker, Dr. David Wing. And note the emphasis on doctor, as David very recently completed his doctoral degree following 4 years of study at, I hope I'm going to pronounce this correctly, at Vira University in the city of Brussels in Belgium. To our delight, he will continue his role as Senior Manager of the Exercise and Physical Activity Resource Center.
Hold it. Yeah.
At UC San Diego. And continue that role as where he oversees all of the lab's day-to-day operations, while also being involved in design, delivery, and dissemination of multiple research studies ongoing, and also education initiatives. So of particular note, David's made a substantial contribution to a global initiative that is known as Exercise is Medicine. And it was created to change healthcare practice to include physical activity as a vital sign, just like heart rate or blood pressure or your body temperature, when assessing patient health status. Our curriculum is taught annually to UCSD preventive medicine residents and a handful of medical students.
Is that okay?
Dr. Wing began his professional career, oddly enough, as a political consultant, working on public health initiatives designed to reduce smoking in public spaces and increase funding for state and national parks. A decade later, he returned to academia and earned his MS degree in exercise physiology from SDSU, followed by his PhD in movement and sports science with a dissertation focused on brain health. His research interests include the use of technology to provide scalable, just-in-time interventions promoting physical activity. Also developing functional exercise tests for individuals with neurological disease, the links between cognitive function and physical activity across the lifespan, and most recently, the potential for remote delivery of exercise programs as through Zoom, for example, for a variety of health conditions, and particularly for older adults. Today, David's presentation is on the Strong Foundation's Fall Prevention Exercise Program, which he had actually envisioned 4 to 5 years ago when we were conducting a study on older adults and exercise program on fall prevention among older adults. And at the time when COVID hit and the facility, of course, as all facilities and like it, were shut down. I have to say I was highly doubtful that it would ever work. But now, 5, 6 years later, he has proved me wrong. And so today's talk, he's going to catch us all up to date on the status of our Strong Foundations exercise program. All right, so with that, David, I'll turn it over to you.
Thank you so much, Dr. Nichols. It's a pleasure to be here. I think I've spoken to this group a couple times, but it is an extra special pleasure for it to be out for the first time as a doctor. This Strong Foundations program is very near and dear to my heart. I think a not small number of you participated in it, and I'll just do my pitch right here at the very front. In 3 or 4 months, we're going to be enrolling another batch of folks. So hopefully this wets your whistle to be interested in joining up in the fall. And we'll make a note, we'll make an announcement at this group when it's enrolling. But anyway, so without further ado, Strong Foundations, which is a digitally delivered fall prevention program. And funnily enough, Dr. Nichols mentioned that we instituted this during the period of the COVID not meeting in large groups. And we had actually, Dr. Moran, who along with Dr. Nichols is a key, and myself, key people in putting this together, and I were sitting talking about how I wish that I could give instruction to some of the family that I have that live in rural Arizona about bone health issues, but I was concerned that if I just give them a video or something, they wouldn't have anyone there to watch them do it. And so we actually envisioned this a couple of years before COVID, and then COVID gave us the push that we needed to really move forward with it. So a little bit about what we're going to do here. This is an overview. We're going to talk about why does this matter, and why did Strong Foundations, why was it created? How did it launch? What did we do? What happened? It's very promising, and then where we're going with it next. So you may or may not be aware of the challenges that are being faced in terms of the fall prevalence across the United States. So this is a little heat map of showing you how many people fall in different states around the United States, and happily California does well. But you can see there at the very top, right, about a quarter of people over the age of 65 and about half of people over the age of 80 fall annually, and that's getting worse. So there's just a lot of falls out there. And while this is the Bone Health Interest Group, I often will say to people in general, if you don't fall, you don't fracture. And so fall prevention is, hand in glove with bone health. So why are people falling? Well, there are, I'm sure you are aware, there are strength changes and changes in musculoskeletal mass that happen with age. So there's a phenomenon called sarcopenia, which I think we've had talked about in this group before, but sarcopenia is low muscle mass. And you can see here in this diagram, right? This would be, say, a 35-year-old muscle leg. This would be maybe a 65-year-old muscle leg, and then this might be an 80-year-old muscle leg, right? With just the volume of muscle really decreasing. And then we also lose strength over that time. And then we have bone density changes. This group knows very well about that, right? We lose bone density. We have changes in our range of motion and worsening posture. And all of those come together to really contribute to a lot of fall risk issues. So you can see here an example of the posture. Normally when I'm in a call and response space, I say, well, what do you see different? But I'm just going to tell you, because this person has some kyphosis, which is the hunch of your upper back, their weight is out over the front of them, right? So their center of gravity is no longer over their center of mass. So they're always forward a little bit. And you can see here the angle of the feet do not set somebody up for success in not falling when you walk. The chance of catching your toe is much greater. And then the swing of the arm as well, and the way that that helps us to maintain our stability over a wider range. So we have several things that are working together, right? A change in posture, a decline in our range of motion, worsening muscle strength and mass. And then there's some changes that happen in terms of our sensory components of balance, right? So my eyes are not the same as they were when I was 20, and I'm sure that you all have experienced. There's also changes to your vestibular input, which is kind of what's happening on your inner ear. And then somatosensory is a fancy way of saying how your feet and your head talk, or your feet and your brain talk to each other. And all those things get a little bit worse with age as well. I do want to point out posture is a particularly important component of bone health, because while I do say, and I do believe that if you don't fall, you don't fracture, there is a much, much higher risk of spinal fractures just from doing life. And particularly doing things like taking steps. And so I want you all, next time you take steps, be very aware that you can step down where you're controlling your rate of decline by, using the muscles of the leg on the upper step, or you can essentially fall 4 inches and you've come down on a step very hard, right? And while that's not, of course, no one thinks of that as, oh, I didn't fall down 21 times because I went down a flight of stairs. But you certainly can have that sort of impact like a very short fall. And so spinal posture, and kyphosis in particular, means you're hunched over, right? So the spinal bodies are touching each other. And every time that fall happens, that 4-inch fall of a step, those bones can come together. So posture is a place where we can improve our bone longevity and reduce fractures, even when falls don't happen, which makes it, and bad posture contributes to falls. So posture is an extra special important thing when we're thinking about fracture prevention. So there's a lot of intro here. That's what helped to build strong foundations as an idea, though. So there's lots of programs out there that can decrease fall risk and falls. And we maintain that technology can increase access to high quality programs. Now, here in San Diego, we're really spoiled because there are exercise specialists all over the place, right? San Diego State puts out a new crop of high level students every single year. And we're the birthplace of the marathon or of the triathlon. And so there's lots of interest in that sort of high quality exercise programming. But if you live where I grew up, there aren't even gyms, much less there being expert instruction. And that's not unique to where I grew up. There's lots of areas that don't have this level of high quality instruction that we've got here. So technology really offers us the opportunity to send people who are really good to people who need them, even not dealing with geographic barriers. And then when we're thinking about older adults and strength training programs and whatnot, there's a lot of barriers to being part of that. And those can be just going to a gym and the difficulties of traffic and dealing with that sort of getting there, right? There's also the barriers of I don't know if I want to hang out in a gym that's not geared towards older folks because I feel funny being there. So these sort of technological interfaces really offer the opportunity to overcome those boundaries. Technological interfaces could be videos, right? And there are some really high quality videos out there, but I really maintain that, especially when you're talking about fall prevention, some of the things that we do, and fracture prevention, some of the things that we do to make sure that you don't fall when you're in life can be just a little bit dangerous if you're doing them wrong. Because they challenge your balance, so you could fall. They also are doing things like strengthening your leg muscles, which if you are doing squats poorly, there's real danger that you can hurt your knee, and that sort of thing can be a long-lasting problem. So that's why I say there are risks to just following a kick when I kick kind of instruction, particularly for older adults. So we envisioned a program that is digitally delivered. So you're getting it through Zoom or Skype or whatever, and then but there's real-time feedback from experts that are helping you to make sure you're doing the exercises in a way that are going to give you the most benefit and also not be dangerous or harmful. So you're getting the benefits, the participants are getting the benefits of what would be real-time, in-person, I'm right there with you instruction, but reducing all the barriers of having to get and be right there in front of people. So a not small amount of work went into this logo, so we're quite proud of it. But right, we've got the posture and then the foundational columns of posture, balance, and strength that make up the strong foundations. So the first pillars of strong foundations, as Dr. Nichols indicated, happened during the period of COVID. We did some kind of finishing that exercise program digitally and some challenges with that. But as part of that, we thought, hey, let's do a fall prevention program. And so we put together some instructions on how do you even get ready for a fall prevention program delivered via Zoom? How do you set up the room? We developed some written instructions that could be given to people to do at-home work based on the exercises that we were providing. And we did a 4-week program with just 12 participants to see, like, is this even possible? As Dr. Nichols mentioned at the beginning, she was highly skeptical. This was at least in part to assuage that concern that this was just not going to be something that people could do or would do. It went well. It went well enough to develop a 12-week program that we launched a full pilot with 4 cohorts and total 39 participants. And for any of you who were part of this, thank you so much. I mean, you are the foundation upon which this is being built. So it again was really very usable and acceptable, and people liked it and were able to do it and enjoyed it. But because of the way we did that, it was again during the COVID lockdown, so we did very little measurement. So kind of knowing, did it help? Like, people will do the exercise program and that's part of it, but did it help people? We didn't really know. So we moved forward. So this was the first pillar, we built the foundation. So we're furthering it after that. We expanded to a larger cohort of people, and we included people who were going to be at a higher risk. We still haven't done a fully high risk example of this. That would be people who are repeatedly falling already or are really showing a lot of muscle weakness, the kind of people who might get physical therapy in a traditional context, where people who are at risk of falling, but not necessarily at high risk of falling. But we included some moderate risk that's weird, some moderate risk people too. We also updated our 12-week program to include an extension program that would go for an additional 12 weeks. That's kind of closer to a kick when I kick class, because the class is much larger. There's still somebody there observing and helping, but they're now, instead of observing, say, 12 participants, they might be observing 30 or even 40. We ultimately enrolled 4 low risk and 4 moderate risk cohorts, 92 total people enrolled, 82 completed the class, 1 person dropping out because they were potentially injured during the measurement, and the other 9 due to scheduling challenges. And then we did a whole bunch of really pretty robust measurements, and we did them both in the lab and via Zoom. This lecture isn't about this, but one of the areas that I'm really interested in is are there ways to essentially make digital health assessment more accessible too? And that's why we wanted to do these measurements via Zoom. So yeah, so that was completely program was completed April 2024. We have the publication out now, which I'm going to be presenting on. But we continued with all these folks for a full year afterwards to find out how many falls there were and how many injurious falls there were. And that just finished in April 2025. And we're really interested to look at those data compared to age-matched national sample. We'll see, I mean, hopefully, you're going to see in a second, we had some great physical outcomes, but hopefully we also help people fall down less because that is the most, most important and distal goal. Okay. So I'm sure everyone loves a schematic, right? This is just showing how we did this. We enrolled people, we did measurement, we split them into groups, we did some more measurement. We did the 12 weeks, we did some measurement, we did the additional 12 weeks, we did some measurement, and then we followed for a year afterwards. What did we do? Again, there's lots of different fall prevention programs out there, and I don't think that there's any such program that's right for everybody all of the time. However, this program really builds on the foundations, if you will, that are about fracture prevention and fall prevention. And they start again with posture. You can see that's the very first focus of the week, and it follows through the entire program. And I mean, I don't know if I belabored this enough at the beginning, but posture is super duper important, both to falls and to fall prevention and to fracture prevention. And then moving on to balance, and the balance includes the idea of using posture and using your limbs as part of your larger body to keep you in balance. And then moving on to what many places start with when they're doing fall prevention programs, which is strength. And then incorporating these three into the foundation upon which everything else is built. And those four classes by themselves really are a potential standalone mini fall prevention program. But then as we go through the additional 11 weeks from from 5 to 11, sorry, I got thrown off track there for a second. From 5 to 11, we're increasingly challenging all of those components to build systematically, and that's based on exercise prescription ideas. And then you can see here in week 12, this is very much of an opportunity for there still to be community like you would have in a class where you go to a one-on-one class. And so we use that 12th week to really highlight that and help people realize how much they've gained over this time in terms of knowledge of how to do things safely that are going to be some everyday activities that you can literally do while you're brushing your teeth. Others that are more focused on exercise and
good. How are you, Roberta?
fall prevention and what have you in a focused exercise manner. Right. Okay. So we screened 141 people to enroll 92. You can see here the reasons that people dropped out ultimately. And then we ultimately completed our measurement on 8. That's weird. I don't know how I muted. So the last thing I know that you heard was that we screened 141 people, enrolled 92, ultimately gathered final measurements on 82, which is a pretty darn good flow through for these kind of exercise trials. The people, it was a largely a female sample. We did have some fellas in there. Any fellas in the group, please really think about joining our next batch. White, highly educated, largely married, with the age there in the younger part of older adults. And then here's something that we're very kind of excited about. Average attendance was almost 10 classes in that first 12-week period. And that's a lot compared to traditional exercise interventions. If you get more than 7 on average, in a exercise intervention, you're doing a pretty darn good job for live classes, which really, again, speaks to the potential of the usability of this to overcome those barriers of getting to the gym and what have you. And then we haven't done this yet, but I'm excited about the idea of being able to take it geographically more extensively. So we gathered a lot of stuff. I know there's a lot of scientists in this group. Some of these things may be pretty interesting to you. Part of what I want to highlight here again is that we did a very robust battery of measurements in the lab, measuring strength, posture, and balance. And then we did a less robust in terms of the number, but still pretty darn impressive number of measurements that have very direct application to fall risk and very direct application to fracture risk by Zoom. And we did that in a way that, again, really reduced the barriers to having to come to a doctor's office or whatnot, meaning that this has potential clinical practice. And I want to emphasize that one of the team members here, I'll show some pictures of everybody at the end, but is Dr. Ryan Moran. And so we developed this with a clinician in mind the whole time. It was not purely research, although certainly research is where I feel like Dr. Nichols and I have the most kind of experience, right? But we had that clinical element in mind. Okay, so what happened? So the timed up and go is an assessment that is strongly indicative of fall risk. It's used by the CDC, or it's recommended by the CDC as a standalone measure to identify individuals who have reduced functional mobility, who are at increased risk of fall, and who have decreased health, right? Increased morbidity. And what it entails is on a stopwatch, you're measured. Somebody says, okay, I'm going to say go, and I want you to go as fast as you can. Walk 3 meters around an obstacle. We use like a traffic cone, and then back to the chair and sit back down. And having greater than 13.5 seconds indicates that you're free, or excuse me, less than 13.5 seconds indicates you're free from disability, although in general, faster is better. So at our pre-measurement, we had about just under 7 seconds. Afterwards, we were down to about 6.75 seconds, with further gains after the additional 12 weeks. This was a statistically significant reduction of 0.2 seconds, which doesn't sound like a lot, but when you think about the fact that the total is 7 seconds, you're getting about a 4% improvement. And 4% in 12 weeks is, pretty impressive, particularly because that improvement persisted and in fact got more at 24 weeks, suggesting that an ongoing practice helps to reduce these. Not shown on this slide, it's also worth noting that the people who were the slowest gained the most. So there is some potential, at some point you can't get better because you're already good at it. 30-second chair stands, which is has a little bit less of a ceiling effect, is another measure that we use. It is exactly what it sounds like, right? How many times can you stand up out of a chair in 30 seconds? It's a pretty robust measure about functional capacity. And think about it, you need to stand up a lot of times in your day. And so ability to do that safely and without fatigue is pretty meaningful. And it's also then a measure of lower body strength, right? If you remember the pictures that I showed at the beginning, the different muscles of the thigh there, the one with the most muscle presumptively would stand up the most times. So, I mean, this is just a beautiful stair step of exactly what we want to see. Maybe I'll put this in the textbook I'm going to write someday about exercise physiology, but at the beginning, we showed almost 13 chair stands, and that went up to 14.5 after 3 months and further beyond that. 1.4 repetitions is clinically pretty meaningful. It's a space where definitely we would feel like, oof, we made people stronger and possibly increased endurance a little bit. This wasn't something we analyzed, but the people who were doing the measurements were saying, gosh, at baseline, people were getting tired at the end of 30 seconds, right? So they started off gangbusters, but slowed down. Whereas at 12 weeks and then again at 24 weeks, they were more able to keep up a consistent, quite fast speed of standing up. And then again, it's worth noting that the people who had the lowest number increased the most, both in absolute terms and then certainly by percentage. And class attendance was a significant predictor of improvement. So you got a 0.5 increase for each class that was attended, which should tell you that the people who didn't come to very many classes actually got worse. They're, of course, in this group, but we're not showing those that attended and didn't attend as a split, largely because the attendance was so good, right? We had nearly 10 classes for most people. The occipital to the wall distance, we'd measured kyphosis in a lot of ways, and a lot of them were statistically significant, but they're a little hard to understand on kind of a layman's level how the measurement is done. Whereas this one, I think everyone will be able to kind of instinctually understand what's being measured here. So in order to test this, you stand up against the wall and you put your butt up against it and your shoulder blades up against it. And then you measure how far away from the wall your head is. And you can imagine that if I asked you to do this and I told you I was going to measure how far your head was, you might be able to stand up really straight and kind of pull your head back, right? So that's one way to measure it. We also measured it when we asked people quite consciously, please just stand like you stand, right? I don't want you to try to be tall. I want you to just stand. So that's what this OWD, that unsurprisingly stands for occipital to wall distance. Normal is with a normal posture, and tall is standing up as tall as you can. And if we go back to what I was saying about kyphosis before, it's an interesting thing because kyphosis is to some degree structural, right? It's about tightened muscles and overly weak muscles, and then also potentially about deformities in the spine that are leading you to lean over. So, but most people can engage their muscles to stand up. And one of the things that we really were teaching people in this class is how to make posture part of your life, right? So every time you remember, you're using this marionette posture. And I want everyone to do this. I won't be able to see you, but you're going to feel this. Just think about a string pulling you up from your head and getting your shoulders over your hips, and just let yourself be lifted up. You're engaging your core a little bit. You're engaging your pectoral muscles a little bit to pull your shoulders back. And feel how that changes the weight on your back, really regardless of whether you're sitting or standing, and about how that engages the muscles to protect the back. Really kind of a critical thing. And so we wanted to see, could people get taller? Was their posture, were they able to have a better posture? And then did they just automatically have a better posture? An interesting measure, we weren't able to do that for this, but an interesting measure would be for, did these classes keep people closer to their tall for more of the time during the day than their normal? Because we did really try to engage the brain in consciously having the best posture possible. So you looked at a slide that I didn't talk about a lot here for a second, but to hit the high points, the normal posture had a 27% improvement, which is a lot. That means that people just were much more erect all the time. And then a 36% improvement when you're talking about people needing to get as tall as they could. So these are really pretty darn meaningful in terms of how much better people's posture got. And again, there were a number of people, roughly a quarter of the people, who had a 0 for this, which means their head was touching the wall, right? So there was no getting better for them. So those, to get these kind of improvements, when you've got some people who don't change, it means that those who had the worst posture are really improving a lot. So this one isn't quite as beautiful for the 3 to 6 month, because you can see there's a little bit of attenuation where the first gain is a little bit larger. And that may be, I would maintain that is because in the second 12 weeks, we have a less instruction available. And so people are not being as reminded to have the good posture, which to me really speaks to why that model of having somebody watching you and cueing you is pretty darn helpful in terms of making sure that we get gains in the the best spots and the most meaningful spots. So it's all very well and good to build an exercise program that is wonderful and helpful and does good things, but if people won't use it, it doesn't matter. So we wanted to measure the user experience quite a bit. The system user, and in particular, the user experience with the idea that this is a technological intervention, not just a regular exercise intervention, although it is also an exercise intervention. So the technological part is what the system usability scale is designed to measure. And it asks a number of questions about, how hard was this to use? How valuable was it? How easy was it? And overall, we did very well with people finding the system usable. Similar, we asked about user experience. Do you feel less fatigued? Did you enjoy yourself? Did you feel watched? Did you feel paid attention to? So here's the system usability scale. Each of these vertical lines is a participant. So you can see there were a few people who were like, this isn't for me. But pretty much the bulk of the population said, yeah, it was pretty darn usable, right? So 87% were above this. 68 is the score that is used when you're saying, hey, is it usable or not? 68 is the score that is commonly used. And so we said, oh yeah, gosh, we're pretty far above that, which really speaks to the ability of older adults to use technology, particularly if they're trained how to use it. And then within the subjective experiences, we asked a number of, what did you think about the class? Was it understandable? Did you feel safe? And again, overwhelmingly, people were very positively, they felt very positive about the instruction, about the level of the instruction that they were getting, that they were being safe doing these exercises, and that the instruction was, special to them. And then this is part of what really spoke to us in terms of is it working, is that people then took those foundational exercises, which again, we're trying to teach people not just to exercise in the class, but to incorporate this into when you're brushing your teeth and when you're doing your dishes. And then of course, when you're formally exercising, using these foundational exercises. And you can see here, roughly 80 either strongly agreed or agreed that they were using these exercises in their life. And this was at 24 weeks. So this is a little bit past the large, high level of instruction. We asked these questions again at the end of the year. So those data aren't available yet, but we'll see how much it persisted in the absence of ongoing instruction. So we've taken this. So that was Strong Foundations 2.0. If who are super interested in it, we do have a publication on it that goes into substantially more detail and is quite sciencey about this whole program and how it did. And we can distribute that to you if you like. Now I'm going to talk about some places that we went from that, because remember that ended about a year ago. So we have since started a digital program for breast cancer survivors. There is, so much evidence to suggest that exercise is important for recovering from cancer, whether that is cancer that is treated with chemotherapy or with surgery, and that it not only helps people build back stronger, right? It also is highly predictive of keeping cancer away. Exercise helps to prevent the cancer coming back. And then Strong Foundations 2.5, With You Every Step. It was a hybrid model in which we took a relatively less skilled individual and had them actually in the room with some higher risk people while our exercises were provided in a video format. So it's a little bit of a hybrid between a Kick When I Kick class and then an instructor there to support you. And that was done in residential living facilities, right? So these are folks who are they're not getting out. And there were some challenges in terms of the amount of space they had within their apartments to do this as a direct intervention. And so instead we brought them into a group space where a trainer could be with them. So with those, we did some focus groups. Did I skip a slide? No. Okay. With some focus groups about what did you think of it? So here are some responses that came up from that. So the overall impressions of exercises we used. The first classes were a little repetitive, and there's other muscles that weren't reached. And while true, that is by design. Again, the idea being that we really want you to focus on one thing and incorporate that into your whole life, and then another, and incorporate that, and then a third, and incorporate that, and then we're going to put them all together because now you have that 4-class foundation that will allow you to do things safely. Whereas if I just start saying, okay, do 27 squats with me, I'm giving you 27 chances to injure yourself. And do you feel safe while performing the exercise? We didn't pull out any specific quotes here, but in 2.5, they felt safe when there was an instructor in the room, but not so much when there wasn't. Some other things that came up, we asked about exercise, these classes compared to other classes. And again, remember, this was a higher risk group. One of the people said, I think that your class is better than physical therapy sessions. I felt that it was focused on individuals and you spent time with us like we needed it. And uh, uh, I thought it's too easy. When people ask me what I thought about it during the first 3 weeks, I said it was all fluff. But then in the 4th class, all that changed and I understood what I was doing. So some interesting responses that people definitely noticed that the first 3 classes were foundational. That's something that as we iterate further, we're going to make sure is hit home even more. So we've had quite a bit of opportunity to take this out to people. You can see we've done a number of posters here at different conferences showing this as it iterated forward, which has allowed us to continue to secure funding because, of course, people say, oh, I see what you're doing here. We'd like to help you go forward. And then a couple of publications in some top tier journals. Hopefully, again, building some additional momentum toward the next steps for this. So summarizing for you, it's a darn good experience for people. It's highly usable. That's been what the feedback has been. So I hope those of you that have done it, tell your friends. Those of you that are available to do this in the fall, please plan on signing up. It's well attended. It's just way above these conventional attendance rates, which again really speaks to the fact that it's overcoming barriers. So even if it's not better, and it is, but even if it's not better than just a regular video or whatnot, it's allowing people to get that experience remotely. Impressive improvements in posture. And again, I'm going to say posture is the key element to fracture prevention in the absence of falls. And then posture is also important to falls themselves. There's some improvements in strength and posture with more for those who had more risk. We didn't have any adverse events in any of these programs related to the intervention itself, meaning it was safe, which I'll tell you what, I have done a lot of in-person interventions and I've had people fall and I've had people get injured. This was actually, I think, because we could really see them through Zoom and we weren't doing things where my back was to you because the person who was giving the instruction was really focused on the group the whole time. We actually probably are safer than an in-person class. And then we did have the one minor event that was potentially related to the measurement. And then we're going to do these ongoing questionnaires, and I'll get to tell you, I don't know, man, in a few months, I hope, about how that impacted falls for the group. So our next step and what we're actively working towards, and you know, if you're interested in this work and are interested in thinking about how you can help us move it forward, please reach out. But we're looking to expand it geographically, so outside of just the San Diego area, but with the instructors in San Diego. The idea being, again, we could take expertise that is local and take it to people who are not local, and that has, you know, very strong implications for helping with disparities with rural health and also helping with disparities with individuals who have difficulty getting to because they don't live in a space that's close to a gym or whatnot, and they can get the same instruction. And then further longitudinally, working to see, how long do these persist, and if we go to even larger classes, will people continue to benefit and enjoy themselves? And then potentially working with higher risk individuals still within that Zoom environment, as opposed to the hybrid environment that we did already. And it's not physical therapy. We don't want to be physical therapists, but working with people before they need physical therapy, right, on those areas that are prone to injury, but so they don't get injured, so they don't need physical therapy. This is the team that put this all together. Dr. Nichols, who is our science guru in so many ways, they're front and center. I'm as you're facing the screen, to her left, Shoshi Barkai to my left, Olivia Colbert to Dr. Nichols' right, and Dr. Ryan Moran, who is my friend and a great colleague in building this, the furthest to the right. So we're thankful to the participants. And again, a lot of you are out there because we literally can't do this without them. It is me looking at Shoshi and Dr. Nichols on the computer screen, and that's nice for a while, but it doesn't really do the job. And so we're hoping to continue establishing these strong foundations for long life. That is the end of my show.
Okay, thank you so much, David. So informative. And I know you love answering questions, so and you're totally comfortable with the chat. So or Cassie sometimes will.
David, would you like me to go through the questions for you, or what would you like?
No, I can see them. So I'll just read out the question and then respond to it. And
Okay,
because there's a not small number, please don't try to ask follow-up questions. Instead, plan to email me. I'll put that in the chat right now, and we can do follow-ups as needed. Okay, so B asked, how does weight contribute to falling? Some health bone experts state low weight may contribute to low bone mass. Whoa, I lost it. Maybe I am going to need you to tee it up for me. Low bone mass, so I get being a bit overweight may help our bones, yet I wonder about falls. Yeah, so it's a good question, and the answer is that so far it doesn't look like heavy people fall more or less than light people, and they don't fracture a lot differently either.
We just lost your audio, David. I think your screen is frozen. Well, that's not good.
Dr. Nichols, you know the answer. You can answer.
Okay, I can sort of finish. Yeah, the literature, I'm not really familiar with literature, even comparing, say, falls and heavy versus lighter weight people. We do know that many of the patients who show up in emergency rooms are frail. Not necessarily small bodies, but overall frail. And I think the big underlying factor is, poor balance, lack of physical activity, lack
Hi,
of strength.
everybody.
Yeah, we lost you, David. So yeah, I was trying to just finish that answer. Let's go on to more because we have so many questions here. So
Sure. Maybe Cassie, do serve them up to me if you don't mind, so I don't have to try to find where I am in the chat.
Okay, no problem. Okay, let's see.
I'm seeing a lot of people who are asking, how do you get on the list? email me and I will put you on the list. Like I said, we don't have a start date in mind yet, but we will definitely reach out to those who have expressed interest. And for those of you who have done it before, we're going to ask that you don't, because we want to get a unique sample. Although Dr. Moran has and I have been discussing the possibility of inviting you when the larger class is ready to launch to join into that, to see what happens when we have 50 or 60 people.
I'm putting your email in the chat right now, David, so you don't need to type it in.
Perfect.
Go ahead, Cassie.
Okay, so Sharon asked, I stand on the Juvent vibration platform every day. It reportedly increases bone density and strength. Do you have any comments about that?
Sure. I mean, the evidence on those whole body vibration are generally pretty positive. I mean, the amount of gain that is being experienced is modest, but any gain is gain, right? So there's nothing wrong with that, and certainly it can be used as an additive to an additive to an existing exercise program. Is it going to help you prevent falls? No, certainly not. Is it going to improve your posture? I doubt it. And does it actually increase your fall risk if you're doing exercises on it? A little bit. So I think, it's certainly not a thing that I say you shouldn't do, but it's not, I think, a replacement for a cohesive and comprehensive strength, balance, and posture-based exercise program.
And may I just add a note on that? It's been a couple, maybe 3 years now, I did a review on vibration machines. So those that have been, developed, sold more recently, not as familiar with, and there's Juvent, not particularly familiar with, but the earlier data showed really mixed results. In fact, I think it's still mixed. And what it seems is the underlying component is the frequency, not the frequency in terms of time, but the machines, those that are made with high frequency vibrations are more successful. However, they are also much more expensive. So if you bought an inexpensive model, you're probably not going to have one that it's going to do anything there. But yeah, as David said, those that have shown success, it's minimal. One particular study I clearly recall was they compared a group that stood on the machine X number of minutes a day, like 10 minutes a day, 3 times a week, to a group that added squat exercise on the machine, and that produced, resulted in some gains in bone, very small, but yeah, I mean, all exercise results in anything that is going to stimulate bone health. It's not going to be huge effects, right? They're going to be, small changes, but think about it. Small changes, if they're positive, really are so meaningful, because we are losing bone, from menopause on in women, and certainly after 50, 60 in men, the trend is downhill. So anything we could do to maintain or even gain a tiny bit would be positive. So, okay. I'm not a fan of them myself, for the other reasons, the balance, the social aspects of it, the variety of things that you do, they're not that practical, I think. Okay, enough of that. No. Go ahead, Cassie.
I'm seeing a couple that are very personalized. So just a reminder again to everybody that we can't take into consideration a personal medical matter, because of course we're not aware of your whole medical picture. So just keep things very general. But we did get a question regarding what height and kind of chair is used in the 30 seconds chair to stand test?
Yeah. No arms and 17 inches seat to ground. So if you're doing it, clinically or properly, and that we tried to get as close to that for the Zoom as we could, which that's basically most standard non-office chairs, the not padded kind, right? The kind you might sit at a auditorium event and in many cases your kitchen table chairs will be similar to that too. Um, but if you're looking to test yourself, then any chair that doesn't have wheels will tell you, have you gotten better with a 30-second chair stand. So yeah, but in the lab we have a very specific one that it's measured exactly and that sort of thing.
Sorry, I forgot I muted myself.
Yeah.
Okay. Do you know if there is a fall prevention or posture class that can be taken in Southern California in the San Fernando Valley that's geared towards bone loss in elderly women?
Well, I mean, in the fall there'll be us. I'm not that familiar with the San Fernando Valley, and this again is really part of what this group the Strong Foundations group is trying to address, is being able to give what I don't know the quality of San Fernando Valley's trainers and programs because I don't live there. But we want to be able to take something that we can say, hey, we have known experts offering this. So I suggest that you look at Aging and Independent Services, though, which is a California state system. It's going to be different in each region. So I don't know what's offered there, but that would be a place on the web that I would start to say, hey, what's available to me.
Okay, great. And then a couple other questions regarding the upcoming program. If somebody has taken it before, are they eligible to do so again? And another question regarding cost and Medicare coverage, if you can speak to that.
Sure. Yeah. So great questions all. No, you can't be part of it if you were part of it before, as we're envisioning it right now. However, we are discussing, we're kind of going through the regulatory process of getting this approved. We're discussing inviting people who have done it before to a larger ongoing class where you would still have 2 instructors, but it would be even bigger. It would be maybe 50 people or 60 people. So the amount of personalized instruction you'd be getting is lower. In order to do that, we would probably have to have some sort of, I don't want to call it a test, and it's still kind of poorly thought out how we'll do this, but making sure that you remember the foundational exercises so that you can safely enter into that class. But so stay tuned. And again, those of you who have participated, if we go forward with that, will be contacted, assuming you told us that we were allowed to contact you again, which most people did, will be contacted with that opportunity. But if you have done it before, then no, we would only invite you to that extended portion.
Okay, and then a couple other questions about equipment. What are your thoughts on weighted vests and also rebounders like mini trampolines?
Weighted vests, I'm super skeptical of unless you're young, right? In your 20s and 30s and 40s, weighted vests are fine. They certainly are going to make things harder, and I mean, I guess they add some amount of extra impact and whatnot. But if you have any bone problems, putting on a weighted vest is adding to the potential that a non-fall will hurt you, particularly if you're not being extra conscious of your posture, right? You can imagine the more bent over you are, the more weight you put on that, you're putting all that weight right onto your spine. So the benefits of weighted vests are modest, I think, and the dangers are high. Now, if you're 22, I have a different story for you. But within the context of bone health in particular, thinking about bone health not on the I'm building it side, but on the I'm preserving it and don't want to fracture side, I would stay away from weighted vests. Rebounders are neat. I don't know a lot about them. They were very popular when I was young, and my parents would do stuff on a rebounder. And I know that they're kind of having a resurgence, but I'm not familiar with the literature in that area. Like intuitively, I'd say, well, you're jumping, and that's good because it's using those fast twitch muscles that will catch you in the place of a fall. But I suspect that they aren't doing a whole lot of bone building because, of course, you're not getting a lot of impact. Did I answer all of them, Cassie?
I think you did, yeah.
Okay.
And actually, we just hit 1 p.m., so we are out of time. David, do you want to make any last comments to the group?
Oh, it's an honor to get to present to you all, and I hope I say this sometimes. If you love me, my name is Dr. David Wing. If you didn't like me so much, I'm Joe Schmo. And I'll be in touch with opportunities. Not personally, but I'll ask there be an announcement when this is fixing to launch again.
Okay, perfect.
Okay.
Thank you, everybody, for joining us. Again,
Yes, thanks again, David, and for everyone's attendance. And we look forward to a new academic year beginning in September. So stay tuned for that. And actually, anyone has your own ideas for topics that you would like